Hey everybody, getting ready to go live with my uncle and talk a little bit about breakthrough COVID and COVID in general. He should be joining here in just a second, and we will get him on. I'm just waiting for his account to join, then I'll invite him, we'll get started. So I hope you guys brought questions. We'll save this and I'll post it up as an Instagram TV video within a day or two. There he is. All right, I've requested him to join the stream here. We should have him just a second. Hey, that's awesome.
Hey, good evening. How are you, Mike?
Good evening. You did so well. This is only his second time on Instagram, so he's a very wise and humble internist, but it's only his second time on Instagram. So I think that was amazing.
That is about me. Anyway, nice to be on Instagram with you and your friends.
Yeah. So there's my mom. She joined in too. So hi, Mom. So I just want to preface. Someone's telling you welcome to Instagram. Kim Elliott's telling you welcome to Instagram. So I just want to start this with my uncle here is joining us. He is Dr. RV Bhat. He is actually a fourth generation doctor, and he's my mother's brother. So my mother is also a doctor, and so she is also a fourth generation doctor. And his two daughters are both physicians, so they are fifth generation doctors, and technically so am I. Since my mom was also a doctor, I'm also a fifth generation doctor, except I'm a fake doctor now. I save social lives. This man still saves real lives by teaching medical students, and he teaches them how to think critically, which is actually, I think, one of the biggest skills. So do you want to introduce yourself just for a minute, and then we'll get started?
Yeah, actually, Mike is a doctor who looks at the outside of the patient. I'm a doctor who looks at the inside of the patient. Mike goes for perfection. I cannot go for perfection because I deal with the complex interior. But having said that, I enjoy what I do, and I see Mike enjoying what he does. So I think today we'll discuss about something both of us are passionate about, that is COVID.
So I want to preface this by saying neither one of us is a COVID expert, okay?
Yes,
but we're both
closer.
We're both doctors.
You're more closer.
Say that again.
Having suffered it, you're more closer. I only saw COVID from others.
Right. So that is true. I have some personal experience, but he is still teaching medical students now, and has been a lung-focused internal medicine doctor for 40 years now. So he's got more cerebral power behind this. But one thing that he said to me the other day, which I took as very interesting, was that COVID has been and continues to be an amazing teacher. You want to tell us a little bit about what you meant by that?
Yes. As a teacher, unless we keep up with what's happening, we will never be able to teach. So a teacher is always a student. When you learn about new things, you become a student learning new things. But new things are usually small, brief, and limited concepts. We have here in COVID an unlimited evolving concept. So much so, we still don't know the disease after almost 2 years. We still don't know exact things about the disease. That's why we are still learning, and that's been a teacher for last 2 years. It's the biggest teacher, making us humble and curious. See, the best qualities of a teacher, he should make the student curious, and he should make the student humble with knowledge. I think this is the greatest teacher for this century.
I think the humility part is difficult. Right now, I think there's a feeling that, and this is a feeling that I have to constantly fight. If someone asks me a question, what do you think of this? I have to fight the urge to do 5 minutes of basic research and then tell them my conclusion. Because 5 minutes of research on my phone is not enough for me to generate a conclusion. And I feel like it's irresponsible, especially if I look like a doctor, sound like a doctor, it's irresponsible for me to come out and give, this is the answer. And I think humility is difficult these days because we feel like we can just look up and get access to our fingertips, you know?
We tried arrogance with the COVID. We thought we know everything about COVID. We told people also it's going to be vanish in 3 months, 6 months. We said vaccine is going to be all and end all. And we said new drugs are going to come. Every step we have been proved wrong. Though vaccine definitely has made a difference. Drugs have made a difference. But COVID is still around there. To a lesser extent, spreading more, killing less. That means, even whether we want or not, our arrogance has not paid the dividends we expected it to pay.
Yeah.
We are forced to be humbled by COVID.
So those, excuse me, every time I get a viral upper respiratory tract infection, I then cough when I speak for the next 6 weeks or so, and this is going to be no exception. What brings this whole thing up? So I was doubly vaccinated. I had the Pfizer vaccine in January, which was the soonest it was available to me. And I went through a roller coaster. I was last year, and even shortly after, all of last year, I was very, very, very neurotic and very, very cautious with the disease. After the vaccine, I started feeling better, a little less, not cautious, but a little less terrified, because the survivability, we can get to that in a minute, 25 times better if you're vaccinated. So I felt more optimistic. And then I'll tell you, in the middle of May, when the CDC basically said, if you're among other vaccinated people, you don't have to be masked. You can really almost live as it were 2019. I really let my guard down pretty much entirely. If I was around vaccinated people, I just acted as per usual. And then a little over a week ago, I came down with the breakthrough case of COVID. Interestingly, my case followed the typical breakthrough pattern, which is chills and fever first. They say the typical breakthrough pattern is about 2.7 days of fever. I had 2.5. And then it felt fine ever since then, with the exception of the cough when I talk once in a while. But that raised my curiosity as to, boy, I thought once I was vaccinated, I was done. And there's more nuance to it than that. So we want you guys, as we go, please submit questions as we go. So here's a good one. Someone just submitted one. Ragumam in my language is Raghu is his first name shortened, and then mom means uncle. So Ragumam, someone asked, does the Pfizer vaccine wear off at 6 months? What do you know about that?
Yeah. When the vaccine came, we thought that the vaccine is forever. But then we realize now that the antibodies which are produced by vaccine, I'm talking of Pfizer as a role model, is waning at the end of 3 months to 5 months, which means the antibodies will become less and less. And the person is vulnerable again to an infection. And this infection, which technically comes after a second dose of vaccine, is called a breakthrough infection. So the breakthrough infection, of course, can happen. But fortunately for us, breakthrough infections are usually milder, and the incidence of asymptomatic infections are more, but the hospitalization requirement and death chances are less in breakthrough infections.
So someone just mentioned they just joined, did I get COVID while vaccinated? The answer is yes. And I should have mentioned, on my main page, I have a good 40-minute video where I discuss this in detail, my post-vaccination COVID experience. You can find it there. One question I get a lot, and I'd like to hear your opinion on it, is if you have had actual COVID, do you feel like that immunity is stronger than the immunity given by vaccination?
Yeah, it's a very good question. Most of the answers, most of the references at this point say that the antibodies following a usual infection of COVID can last for about a year, whereas the antibodies which are generated by vaccines last much shorter, 3 to 5 months. Of course, this is not about everybody. It may last longer in some. Probably the difference comes in because of the involvement of the memory cells. There are the cells called memory cells. They are those cells which remain longer, live longer, and remember longer. So if we can make these memory cells, stimulate these memory cells some way, probably vaccine will be more effective. And interestingly, there is something happening in this angle now. There is a nasal vaccine. So nasal vaccine is being studied. They say that if you give the usual vaccine intramuscularly, it will stimulate immunoglobulin G antibodies as usual, and follow it up with the nasal vaccine. It will stimulate IgA antibodies and memory cells. So this may be the vaccination routine of the future for a long-lasting effect.
So to translate that a little bit for people that are not 100% comfortable with
Yeah.
immunology,
Yes.
it is best. I think it's safe to say that your immunity is best if your immune system is trained to the closest mimic of what you're trying to avoid. So if you're trying to be immune to men, it's better to train to a lifelike model than a straw model. Okay. And so with COVID, the actual disease, I do believe is going to give you more, presuming you live through it, don't have troubles with it. Once, let's say you get all the way over it, I think that person by definition would have stronger immunity
And
because they've seen multiple proteins. Those proteins were being reproduced in their body for days and days and days, not just 8, 12 hours after an mRNA vaccine.
yeah,
And they got that virus through the passageways where they're going to need to defend themselves again later by breathing it in.
yeah,
So it trains the lymphatic tissue, Wilder's ring, where all those tonsils, adenoids, base of tongue tonsils, where that's why you have them there, is to help catch antigens on the way in.
yeah. At this point, I would like to interrupt you, Mike. That is, if you get a COVID, you are facing thousands of viruses. Whereas
Antigens.
if you take a vaccine, it's going to be few virus-like particles or pieces of virus. And the second thing, very interesting thing coming up is if someone gets COVID and takes a vaccine after that, it gives what is called as hybrid immunity, a robust immunity. It is 100 times more than the COVID infection and 25 times more than the vaccine-induced infection. It's one of the most robust immunities one can get. But of course, you have to take the vaccine after 3 months.
So, that's interesting. I didn't know that. So, if you've had wild type COVID, wild type means out in the community, like the actual disease.
Yes.
3-month gap, and then get your vaccination. You're more immune than either category.
Yeah,
Is that what you're saying?
milder variants like you, milder infections like you, the gap is suggested is 3 months. The more severe ones, a little longer also is all right. And that gives a real robust immunity. This is what we find in the current literature.
Yeah, that's interesting. Um, so, ivermectin, big topic. We get asked about this one a lot, and I feel like if I don't bring it up, then it will almost seem like it's being buried. And so I think it's important that we talk about it. You just sent me a review article 20 minutes ago.
Yes, this one.
What have you heard about ivermectin? What first off, tell people what it is.
Yeah.
Why does it have appeal? What is the promise that people say it's got, and where's our current knowledge on it?
Yeah. When in the beginning of the pandemic, we did not have a drug, a single drug, or we did not know till the recovery trial on the 16th of June 2020 proved that dexamethasone is going to reduce mortality. We did not have a drug to reduce mortality. So naturally, whenever we don't have a single drug, we are desperate. We try to search here and there, including trying to use the old drugs. This has a name in pharmacotherapy. This is called repurposing the old drugs. Now, when we try to repurpose old drugs, certain things came up. One was hydroxychloroquine, one was ivermectin. I will speak about ivermectin. Ivermectin is a drug used against parasites, onchocerca, certain worms, and we have a long experience with it. It stimulates the immune system also. It has been used as immunostimulant in the past. Now, the interesting thing about this is this seemed in the laboratory to block the docking of the virus. That is, the virus sitting down on the particular near the receptor and trying to enter the receptor.
For the lay people, I just want to jump in for one quick second. So what he's saying is in the glass petri dish, when you're having cells with that receptor, the ACE2 receptor that COVID latches onto, there is evidence you can see in the laboratory that ivermectin does interfere with that process. Is that what you're saying?
Yeah, this docking. You land a rocket on the moon. It has to sit on the moon first and then enter. It prevents both the docking as well as the entry proteins, the proteins which facilitate the entry. This was a very promising finding, but it did not prove to be so useful in practice. But then, as I told you, it was used in certain countries, large number of COVID, like India, with varying results. Certain studies proved that it is very good, so much so the Indian Council of Medical Research at one point of time even recommended trying this. But after a lot of studies, and I sent you the database today, the Cochrane database, it says being the big no for use after infection, and probably is going on the way out even as a prophylactic.
So the appeal and what really needs to be developed, I think the reason that oral medications you can carry in your pocket and are readily available are so appealing is, so Friday afternoon, let's say I came down with my case, and we called patients that were probably exposed, people that I was in the room with for more than 15 minutes, within 6 feet, et cetera, et cetera, et cetera. But there's nothing they can do about it. They can keep themselves away from other vulnerable people until they wait out an incubation period and everything else. But there's a real desire. We want to be able to put something in our mouth at that moment and say, okay, now I've done something, and I think that is a very appealing concept. But in what we've seen so far, we can't. So the docking and the binding and the internalizing process is blocked in the laboratory, is decreased in the laboratory, but at concentrations that you may not be able to achieve with some oral pills in your bloodstream. That's the problem. It takes so much.
Yes.
And so right now, the best we can say is this meta-analysis just came out a couple days ago, the one you just shared with me, is that we don't yet know if it helps or hurts. But there are 31 good studies underway, 31 well-designed studies underway now.
Yes.
And we may find out good or bad information, but the best we can say now is there's molecular reasons to want to believe in it. It would be fantastic if it worked because we have something we can do. We don't yet know, but we should know in several months. I think that's the fairest answer to that question. What do you think?
Yeah, I agree, fully agree.
So
we can't depend on it as of now as a preventive measure.
yeah. We have a bunch of people saying that that helped them massively during COVID, and I think that's terrific. And I'm glad it helped. One of the tricky things is I had someone say to me, I told them I got COVID after being vaccinated, and my symptomatology lasted, 2.5 days. And I believed that was because the vaccine helped, right? And they said to me, but how do you know it was the vaccine that helped you? And this is kind of what's difficult with trying to look at individuals and ask, well, with that individual, how do you know chemotherapy cured that individual's cancer? My answer was, it's kind of like using a condom in pregnancy. If you have two groups of people, okay, in the group of 10,000 people that doesn't use condoms, you're going to see a lot more pregnancies than the group of 10,000 people that uses condoms, okay? But you can't look at any one person that didn't get pregnant and say, well, maybe if you hadn't used a condom, you still wouldn't get pregnant. That is true. If they hadn't used a condom, it is technically possible they still might not have gotten pregnant. But the behavior of the groups are very different. So each individual, you really cannot look down at one that didn't get pregnant and say, for sure, the condom saved them. You're right. You absolutely can't do that. But when you look at groups, it helps to look at big numbers. So I think that's the best way to understand when someone says, well, how do you know for sure in your case that was the way? Well, because
one more, I would like to interrupt you at this point. There is one more thing that we don't look at because we can't look at it easily enough. There are two arms of immunity for any vaccine. One is the cellular arm, one is the humoral arm. Humoral arm can be calculated, that we can see the degree, what is the antibody percentage, what is the concentration. Whereas there is a cellular arm, which we are neglecting and ignoring all the way. There are now tests coming up to see the T cell effects, not available easily. So probably in your case or case of certain people, the T cell arm might have helped. Despite the B cell, and that is the antibody titers being low, if someone doesn't get infection, it may be because of a robust T cell response and a T memory cell response, which as of now we cannot make out.
So, again, translating a little bit for the lay people, I think now our lay population is much more aware of the concept of antibodies fighting current infection.
Yeah.
And antibodies, you can think of them as little proteins that latch on to targets and have the killer cells that are always floating around, directs those killer cells to those targets. But there's a whole different kind of immunity in our body where actual immune cells are trained to recognize things without the need for being targeted by an antibody first. And those are these other kinds of T cells he's talking about. And so what he's talking about is it's those antibodies are readily generated by just drop a protein in the vaccination, but they're not. The training the T cells is harder. Is that accurate? Would you say it takes a more accurate simulation?
Yes. Is the T cells are like bouncers, whereas the B cells are trained fighters who generate the emulation later. The T cells are like bouncers who try to prevent and stop this, so they take them to the B cells. And B cells are going to produce an ammunition to prevent the entry of the virus altogether.
So here's another question. If you have had a severe reaction to 2 flu vaccines, hives for 5 days the first time, eyes swollen shut, shortness of breath, not true anaphylaxis, should I risk the COVID vaccine?
Well, it's a difficult question to answer in a yes or no manner. But what is today recommended is what is a severe reaction? Is it anaphylactic? And what is the reaction to? Is it to the vaccine or the polyethyl glycolate component of the vaccine? In other words, only time when you have to be very careful is severe reaction like anaphylaxis. Severe reactions more than one, like your friend had, multiple allergies to drug, to NSAIDs, to food, to vaccine. These are the situations where you have to be careful. Having said that, many times people think local reaction, redness, or fever is allergy. It is not a allergic manifestation. Allergic manifestation is the true allergic manifestation of anaphylaxis if it has happened or near anaphylaxis, which means cough, breathlessness, choking. Anaphylaxis involves choking. If that has happened, probably you should never venture it again. And if you have 2 reactions of varying severity to fruit shots, I think it should be mentioned. And if at all you are taking this one, that's your decision and the decision of the doctor. They have to be prepared for anaphylaxis.
So we have a concept in medicine we call an allergic personality, and this has nothing to do with your personality. It has to do with the behavior, the overall tendencies of your immune system, because the immune system is responsible for allergy as well. And so there are some people, you probably know them, they're allergic to everything. They're allergic to cats and to pollen and to wheat and to beef. And if you were to invent a brand new food and give it to them, they're going to have a much higher likelihood of being allergic than someone who has none of those other allergies, because their immune system in general is just really good at being allergic to things. And so what he's saying is if you in the past have proven yourself to have an allergic personality, 2 or 3 different other vaccines made your eyes swell shut, et cetera, et cetera, et cetera, you are at higher risk for allergy to not only the COVID vaccine, to a new fabric softener, to a new antibiotic. You're at higher risk for allergy, period, because you have an allergic personality. Now, if you weigh out those risks and benefits and still want to get the vaccine when you talk to your doctor, you need to be in an environment where if you do have a sudden allergic reaction, they're ready to treat you. So you don't get this vaccine at the drugstore in the corner. You get this vaccine in a hospital. So if you have a problem, you're already in a hospital.
One more thing here. My own cousin, she had a life-threatening anaphylaxis for eggs. She has taken this vaccine without any problem. Of course, there was a lot of discussion, and she went on, discussed with her doctor, and then finally decided to give it with, prophylactic measures if the thing happens. And she took the first dose, nothing happened. Now she's due for a second dose. In between, she developed COVID. Now 3 months have passed. She's taking the second dose. So egg allergy has nothing to do with it.
So egg allergy in particular is not a big deal. Here's a great question. What do you think about getting the vaccine while breastfeeding? Is there any established medicine out there for that?
Yeah, the references as of now say that the data is insufficient to give a yes or no answer. But Pfizer trials, which are ongoing, have said that it is safe. But the final yes or no has to come from the authorities. It has not yet come.
So again, I think this is one of the most I think this is one of the most important concepts in that I think
Yeah.
the, I keep telling you how good of a teacher and wise this man is. The smarter you are, the fewer blanket statements you make. The more educated you are, the fewer blanket statements you make. So notice he didn't come out and say, "Oh yeah, it's safe." He said, the jury's still out, um, but so far it looks like it's been safe in the Pfizer trials. So I will tell you what I would do, and this is not medical advice for you, but this is how I think about it. Okay, when my wife was and we were both younger, and she was nursing our children, if we would go somewhere and she would have a glass of wine, or she took an antibiotic or something that we didn't want to get into the kids, so to speak, our pediatrician recommended pump and dump. They called it. You uh, for the day or two after the event, you give the child reserved breast milk that was previously stored, and you pump and discard, right? When you get the COVID vaccine, the mRNA one especially, that protein is only being made in your muscle for several hours, you know? So maybe if you want to split the difference, one thing you might consider, and discuss this with your pediatrician, is maybe you get the vaccine, and for the next 24 to 48 hours, you pump and dump. So whenever that protein is actually in your system, so to speak, that milk is being discarded. By that time, the protein has stopped being made. All you're making is antibodies after that. And maybe that might help you kind of justify, or what do you think? Is that a reasonable approach?
Yeah, I think so. I think it's a reasonable and an intelligent approach.
Let's see. I'm looking for other questions. Oh, whoops, that already in there. Okay. I'm
Honestly,
past
one
my.
question I expected was vaccination in children.
What? Let's bring that up. Vaccination in children, and let's maybe
What,
talk about a few age groups. Go ahead.
well, there was a time we believed that children won't get any infection, or if at all they get, it'll be mild. We completely ignored that segment. And then we realized that they can get infected and they can be asymptomatic, and they may be the source of infection for the family. They may bring it from school. But what was really woke us up is one of the recent events in Indonesia, where a lot of children had COVID. The variant came this time. The second wave came with the third wave came with the involvement of the children. So much so, 12% of the total population involved were children, and 12% of the deaths were in children. So the vaccinating the children is a reality now, and it is believed that in some of the countries, at least, the third wave may be involving more children than adults, percentage-wise. So vaccinating the children has started, and 12 and above, it is being done. You might ask me, what is the difference in the dose? I'm talking about Pfizer. In adults, we give 100 micrograms. Here we give 30 micrograms. We give 30 micrograms in adults. In Pfizer, here we give 10 micrograms, one third. 30 microgram is the adult dose twice with a gap of 3 weeks. Here we give them 10 micrograms. Now there are trials being done because this much is approved. We can give it to 12 years and above. Now, if you ask me about less than 12, 6 years, what would you do? There are trials ongoing in Finland, Spain, US. They're using 5 micrograms. And younger children, they're using 2 micrograms. So they are actively doing these trials. So I feel soon they might introduce these dosages for children. So vaccinating the children is a reality and probably is a need to prevent further outbreaks, particularly from the variants.
I want to jump back to the pump and dump. Someone says and I don't know if this is true or not. I was just learning it right now. Said that there was a Harvard nurses study that found and I'm not sure if it's the protein or what, in the blood weeks later. So if that's true, then maybe the pump and dump approach, if you're really worried about it, may not be it. But again, just something you can think about it. At least it would be less than. Here's one that I get a lot: interrupted or changed menstruation because of COVID. Um, do you have any
No,
information on that?
I
Okay.
have not come across, after extensive reading, not come across any changes in menstruation or fertility.
Yeah.
That was a concern in some of the underdeveloped countries, but no. we are not finding it. There is a certain amount of misinformation in certain pockets. This has happened with polio vaccine, and this is happening with the COVID vaccine. Probably it's one of the anti-vaccine lobbies great worried about a possible reduction in fertility, but no single trial has shown it. Not even one trial, well-designed trial. No.
Another question. 10 days out after COVID, still have some symptoms, testing positive. I don't know if it's the person that put this in here didn't say if it's antigen test, PCR test, what. So 10 days out, still have some symptoms, testing positive. Is this person a risk to spread it to other people?
Yes. The point is, if he's symptomatic, as symptoms like the original COVID, we take it as is still spreading. And 10 days is okay. It can be taken as still active. But if the test remains positive, but absolutely asymptomatic, more than 2 weeks have passed, let's say 1 month has passed, and still remains positive, it is the presence of RNA. Now, unfortunately, the PCR test that we do doesn't tell us whether the RNA is from a live virus or a dead virus. This is called the lingering RNA phenomenon. Unfortunately, some people get into trouble. They're luckily few and far to by, but if they come positive, they are unduly suffering because they are not allowed to come out into the society. So this, if the patient is symptomatic and positive, within 10 to 14 days, it is advisable that he takes it as active COVID and use a mask. But if it's asymptomatic completely and long after COVID, like symptoms stopped after day 14, day 30 still positive, it's unlikely to be spreading.
So let me ask your opinion on this. So right now, the current CDC guidelines, if you've been vaccinated and come down with COVID, they want you to be quarantined for 10 days and afebrile for at least the 72 hours leading up to the end of those 10 days.
Yes.
They don't say anything about fully asymptomatic. So let's say, taste and smell, for instance, that might linger 6-12 months.
Yes.
Is what they don't have a test. The CDC right now they don't have a test-based criteria for exiting quarantine. It's a time and symptom-based criteria. At least 10 days, no fevers for 72 hours.
Yes, true.
How do we square that with, okay, but they still have a little bit of sore throat, or they have no smell, they still have no smell?
Well, there are two answers for this question. One, there is a concept, or there is a entity called long COVID. Some of the symptoms may last long, and very good studies from very good centers have shown that certain symptoms can last even 1 year. Fatigue, tiredness, pains, aches, inability to work to the fullest extent, some cough, some breathlessness can last for even a year or so. But this is a non-spreading COVID. This only this person suffers. But the other one that you're mentioning is where the person symptoms not much long after COVID. I would say that you do a test, PCR. If he's negative, probably he's safe to go out, but he's suffering. That's unfortunate.
Yeah. So listen, someone else mentioned, back to the breastfeeding topic, if milk is made from the bloodstream, does the protein ever get into the bloodstream and therefore the milk? I would expect probably, right?
What is the question? Whether
if you are immunized, while you're producing
antibodies.
the protein,
okay,
generate the antibodies, is it likelihood that the protein that you're making from that mRNA probably is also passed through the breast milk? Do we know the answer to that?
It is said that it is unlikely because it goes from the cytoplasm. This protein is made in the cytoplasm and not in the nucleus. It doesn't alter the nucleus. So it's unlikely that it goes into the spike protein goes into the fetus. Well, the immunoglobulin, yes, it can go.
The antibodies are saying yes.
Antibodies,
yes. Yeah. Lactation consultant here. Breastfeeding after getting the vaccine is fine. Thank you very much for that.
I agree with it.
Yeah.
I don't know. I agree with that. Lactation expert.
Yeah. Do you think COVID will likely be a disease, let's say, like HPV, meaning most humans are going to be exposed to it at some point?
The
Or can,
most mean in the sense, there will be a time when most people will be exposed, and probably a herd immunity will develop unless variants come in. Now, the what upset the balance of our knowledge was variants. This brings us to a concept of variants. If it was the same virus, by now we would have had some kind of a control. The virus is intelligent, enemy is intelligent, it's changing its shape, size, and its mutation. So it becomes different. And that's where the problem comes. The answer for this is very difficult. If it was the same virus by now, probably we would have had a very good control with vaccine. So it is possible, but it may take long for the virus to mutate.
so I want to, for people that aren't super into viral replication and mutation, I want to give just a 1 minute summary of what it is, what it means. So we have DNA replication mechanisms that are incredibly precise, and we have the ability to catch mutations as they're being made in our body and quell them, so that if we didn't, we would all develop cancer instantly, right? Because if every time we had a missed copy of DNA, first off, if it happened a lot and then we didn't have a way to kill that cell, there'd be so many mutations we'd all develop cancer just within a heartbeat. Now, viruses are teeny tiny little organisms that are missing. They don't have enough room. They don't have the machine is too small for all those gears. There's not enough in there to have a super high quality replication mechanism and to have the self-policing any errors get quelled mechanism. And they reproduce so quickly, tens of thousands of copies, millions of copies over the span of weeks, that there is a high error rate, fast reproduction, and no checks. So you're going to get hundreds of errors, just error, tons and tons and tons of them. And you probably heard the expression, if you give an unlimited amount of monkeys, an unlimited amount of typewriters, and unlimited amount of time, at some point one of them is accidentally going to write Shakespeare, right? And that's what happens with viruses, with unlimited mutations happening so quickly. They mutate fast because they're incapable of reproducing accurately. At some point, one of those mutations is actually going to be better at doing harm than the reached version, and more communication and spread more readily. And that's how viruses get more virulent. The word virulent literally means that. So by accident, this mutation spreads easier. It happens to copy in more copies and go out more readily. And there are for this one, there were 10 million other ones that were less effective, but the less effective ones don't make it out anywhere. So that's kind of how viral mutation does this.
I would like to interrupt, Mike. There are two interesting things here. One is certain viruses, they go on mutating and suddenly they become less virulent. Even that's possible. The mutation can make them less virulent. It is said that they can mutate, and go off the cliff and disappear. This might have happened with Ebola. The virus is very virulent, 50% mortality. We are talking of a disease where every other person dies. Suddenly it seemed to become less and almost hardly there now, and it didn't spread much. Second thing is, they were digging for making a new building in Oxford. They found 4 cadavers buried underneath, and one of them had smallpox, died of smallpox. So there was active smallpox virus in that. Even after 1,000 years, they found smallpox virus. And the virulence of this, when they analyzed, was much, much more than the last smallpox virus, which is preserved in the lab, 1970s. So this showed that on 1,000 years, the virulence became less. I'm speaking one of the deadliest diseases mankind ever saw. If that has happened with smallpox virus, it's hoped that mutations may, it's a wishful thinking, reduce the virulence and potential, the transmissibility of any virus. And we hope that happens with COVID too, at the rate of which it is multiplying.
Well, that, as you said, that happened with Ebola, and that happened with MERS, Middle East Respiratory Syndrome.
Yes.
It happened with SARS-1, the original SARS.
Yes.
And up to this point, I remember being very hopeful in the spring and summer of 2020 that we were going to see this kind of burn itself out a little bit too, because again, that's been the natural history of many of these. In some cases, the worse the virus, if it gets so bad that it kills the host instantly, it's hard for it to spread. So the common cold is a very effective virus because you will go about your life. You carry it around with you all day long and give it to 30 people because it's so mild. Yes, I'm going to save this live. So here's a question. I don't know if this is answerable. If we keep getting variants of this virus, will there ever be an end to this pandemic?
Very difficult question to answer. Unless, many people get this infection and less people get the disease at one point of time. Now, I would like to deviate from the question a little bit and tell you that because of the Delta variant, a person who has been vaccinated might get asymptomatic infection and maybe unwittingly spreading it to unvaccinated people. That brings up the question of using mask. So probably to answer the question, vaccine alone is not enough. Infection alone is not enough. We have to use personal protection like mask. So if you go back to personal protection, this may come true.
So this to me is a very challenging concept because there's always this constant tension between the concept of personal freedoms and societal impact.
Yes.
And so I want you to take my specific case, about 2:30 in the afternoon, one day last week, suddenly became symptomatic. Chills first, a couple hours later, fever. Do you think I was not infectious at 2:29? Do you think I was not infectious at noon that day? I was clearly infectious.
Yes.
2 hours. 2 hours before I became symptomatic. I was definitely infectious. There's no way that suddenly the virus came into me, created the symptoms, and I was only infectious at that moment. So now, how long before I developed symptoms was I infectious? That's debatable. But let's say an hour before I developed symptoms, I was definitely infectious.
Yes.
Had I been wearing a mask, catching my droplets on the way out, masks are best at source control, I would have had, and God willing, I didn't spread it to anybody, but I was still in this, I've been doubly vaccinated kind of dream state where I thought, honestly, because the CDC said so, we're looking pretty good, right? So I felt pretty good about it. But had I been wearing a mask in the hours leading up to my symptoms, the chances that I spread it to someone are less. But if you said to 1,000 people like me that were about to become symptomatic, you should all be wearing masks in case you become symptomatic an hour from now, some fraction of those people are going to say, why? I feel fine and it's a violation of my personal freedom. And that's a challenging concept. And I'm not saying those people are wrong. These are the things we need to think about back and forth. And what's right is for everyone to decide, but that's the reason. So why do you put asymptomatic people in masks, even if they've been vaccinated? Because like me, at one point, some fraction of them are going to flip and become symptomatic, and they have been infectious in the meantime. I definitely had live virus. I know because I got sick.
I think you're right, but then there's the other side also. That is because if you got the virus, which is not a variant, you are right. If you got the virus, which is a variant, we now know that you can spread it to others more easily, and they may get a more severe infection if they are not vaccinated. So it's a very debatable point, but I would say that masks are coming back.
Yeah.
With the Delta variant coming more and more often, the masks are coming back whether we want or not, and it will be the decision of the wearer whether he wants to protect himself, and the patient whether he wants to stop spreading.
So I think back to the condoms analogy. We as a Western society are hyper focused on pills and shots and things that you do that are high tech, that are being developed, and you develop a solution. Back to the condoms analogy, the specific question they asked was, is this going to become something like HPV where lots of people are exposed and lots of people have it? Well, if you put a condom on everyone every time, whether they think they're with a risky partner or not, guess what's going to happen to the HPV rate, right? it's going to go way down. And it has nothing to do with a magic therapy for HPV. It has to do with just basic barrier functions.
But if we are going to get a nasal vaccine, I think the scenario may change. If you get a nasal drug, a post-exposure prophylaxis like thing, if I feel that I'm exposed, if there is a drug which can be sprayed on my nose, I think this is going to be a good answer for that question. Research must probably show up with a drug which can be used nasally after exposure. And second thing is the use of nasal vaccines, which may bring in a large number of people who are reluctant to take the may agree to take a nasal vaccine if it is proved to be beneficial. Particularly, can easily immunize children.
Yeah. I think whatever it is, whether it's a nasal drug post-exposure, I think one of the biggest breakthroughs right now is, again, the easy thing to do would be to help, put a condom in everybody's face, right?
Yes.
But second to that, the biggest breakthrough that I really pray that we have someday soon is whether it's ivermectin or whether it's some other molecule that they develop or they pull out of a library, whatever it is, that in the next 4 or 5 months, we say, you know what, we found it. You got exposed, go to the health department, they're going to give you a packet, and you take 5 pills and you're done. A morning after pill, if you will, right? And that's a controversial concept, but just think of it this way. If you didn't use birth control, but you've had an exposure, there should be a morning after pill. That is, I think, the next biggest breakthrough that I think we wish we all had.
The post-exposure prophylaxis.
Post-exposure prophylaxis, yeah.
It has come in HIV, it will surely come in COVID, but unfortunately, the virus is mutating, so they have to find something that is going to tackle the whole virus, not the spike protein.
So that's an interesting point about it happened to HIV. So we're both old enough to remember when HIV emerged, and it was lethal. I mean, it was a guaranteed death sentence.
Yes.
Right? Everyone that got it died, except very rare, innately resistant people, but 99.9% died. And then eventually we developed drugs where you could take it and it would convert it to a chronic illness that you manage. And now variants of those same drugs, you can use post-exposure or even pre-exposure prophylaxis. You take them and it decreases your risk of converting if you're even still exposed to the virus. And so, remdesivir, wasn't that an old HIV drug that they repurposed and had some benefit yeah.
They tried the lopinavir, ritonavir combination, and the recovery trial said it is not as good as it was thought to be.
But the concept is hopefully we develop something like that.
Yeah.
Would either of you guys vaccinate your younger children? If you had children, let's say Geeta has a 2-year-old granddaughter under 6. Would you vaccinate that person?
Yeah. The point is, number one, what is the environment they're staying in? Number two, if they're going to a school, I think they have to be vaccination available. I think they have to be vaccinated because it's very difficult to expect a child to wear a mask. They won't understand. And if a vaccination is available, probably it's a wise thing to immunize them. It will take a while. Lots of studies going on, and soon I think it will be a reality at a lower dose, 5 micrograms.
One of the questions I get a lot is, aren't you afraid of the potential long-term problems that you might see? We don't know it. We don't know what the consequences of vaccination in this child might be 10 years from now, in this adult might be 10 years from now. We don't know what the consequences of vaccination might be because it's a newer type of vaccine, 5 years, 15 years, 30 years from now. My personal take on that is I wonder what the consequences of me just having COVID are going to be 2 years, 5 years, 30 years from now.
Mm-hmm.
I don't know that either. And I would love to have avoided that as well. What is your thought on the this is a new style of vaccine. What is the worry with 2 years, 5 years, 20 years from now?
Unfortunately, the studies are done only till 6 weeks after vaccination. The adverse effects are studied only for 6 weeks as a rule. And then whatever is studied after that is when the cases come. For example, if there is an unusual type of stroke in a young person, they go back on history. The COVID vaccine was taken within 14 days of this event. They connect the two. But if it is more than that, it's difficult to connect the two because there are not many studies. So only time will tell us. That's what I say. It's a long-term teaching. The COVID, vaccine, the complications are all long-term teaching. Very interestingly, we find when the acute respiratory distress syndrome comes in adults in some of the unfortunate patients, some recover fully, no problem at all. But some develop the lung as hard as, very hard lungs because of fibrosis. See, we think that fibrosis is a slow process and takes time because we see it in tuberculosis and interstitial lung disease.
When
But
he
we find
says
it happens in a week's time.
fibrosis, he's what we colloquially we say scarring of the lungs.
So
Yeah,
scarring happening rapidly is seen in a few patients, which is something we did not know will happen.
with the disease you're talking about.
With COVID, yeah.
Yeah, not the vaccination.
Yeah, not the vaccination has not proved that.
So here's someone, personal experience. They gave me remdesivir in a hospital along with steroids, and it helped so much. What's interesting is you got two drugs, remdesivir, steroids, and as if you're here earlier in the conversation, you would have heard my uncle say, the steroids have been the one drug that is totally proven to really help post-COVID, correct?
Yes, but I would like
Not
to ask
totally, but
the person, when did he get this? Which day?
yeah,
Because
it doesn't say.
antiviral drug and steroids prevent the hyperimmune reaction. So they are best given after a certain time.
Yeah.
Whereas the remdesivir, if you're giving it in the initial period when the virus is still active, within a week. Whereas steroids only after a week. One of the common mistakes which is made and which should not be made is to give steroid early and anticoagulants late. It's the other way around.
Let's talk about anticoagulants.
Yeah.
So that was a question that came up earlier. We used to hear a lot about blood clots, strokes, hypercoagulable states being really common in COVID, and we're not hearing about it as much anymore. Is that still a common thing, or is that less common now?
So definitely less common. Anecdotally, it was said that one of the hospitals, the nephrologist met a pulmonologist in a canteen, and the pulmonologist said, there is hypoxia. I tried to give them oxygen and they die. And the nephrologist said, I tried to dialyze them for acute kidney injury and they don't get dialyzed properly. Both of them were speaking about the thrombosis. At that time, thrombosis was not known. It is the Italian studies. 50 cases of meticulously done autopsies in Italy showed that the vascular thrombosis is an ongoing process, and that opened our eyes. And only then we thought of hypoxia due to this, the vessels getting blocked. And then they started giving anticoagulant. And the anticoagulant like heparin and enoxaparin are allowed. And oral apixaban is also allowed in mild cases. So it has come to stay, definitely making a difference. The second thing that reduced mortality was anticoagulant.
And when you're saying making a difference, you're talking about truly ill patients, hospitalized patients,
Yes.
not the case of COVID at home.
No, it's not COVID. It's over. Virus phase over. The body reacts too much. That's called the hyperimmune response. Goes by various names: macrophage activation syndrome, cytokine storm, bradykine storm, whatever it is. To put it very simply, it is exaggerated immune response gone wrong. The army is fighting its own people.
What I was asking as well is, when you're saying anticoagulation has been shown to be beneficial, you don't mean for everyone that gets COVID. You mean for people.
I mean for the person who is in the second week of the symptoms, who seems to be having cough and breathlessness, whose oxygen saturation seems to be going down, not getting good results with oxygen, and his test analysis, the D dimer levels are rising, the ferritin is rising, CRP is rising. Something is going wrong with the inflammatory system, and those are the people who require the anticoagulant. The D dimer people require anticoagulant, whether they are symptomatic or not. This is very interesting. Sometimes what happens, everything seems to be all right, and we tell the patients, it's going home, and we do the D dimer, it is 2000. What do you do with it? You have to anticoagulate because Many of them die. Is looking asymptomatic, but high D-dimer. This is a very, very, very difficult thing, but you have to treat. Whereas if your ferritin is high, CRP is high, LDH is high, they are the markers of inflammation. They will do better with dexamethasone.
Interesting. So we have about 2 minutes left before it cuts us off. Do you have any final thoughts that you want to say?
Final thoughts? Yeah, I'll end it with a positive note. Though we started with the disease which we didn't know anything about, many people are dying, we didn't know why. We tried, we were separated from our kith and kin. Well, people are still dying, people are still getting hospitalized, but to a much lesser extent. So vaccine has made a difference. We have to take a vaccine.
No, for some reason your sound went away. You were right there in the end of it. I don't know why, but your sound just went away. Can you hear me? Not if you can hear me. Can you hear me? I can't hear you for some reason. You totally went away. That's interesting. Well, guys, our live was about to end here in 2 or 3 minutes anyway. I'm not 100% sure why his audio feed cut out. I'm so glad we had the. I wonder, maybe did you hit a mute button on your? Is there a button sound button on your side? I'm sorry. But anyway, I'm so glad we got him for the first 55, 56 minutes. I don't. Oh, under your mouth, there should be a little microphone button. See if you can see. It's right on the bottom part of your piece of the screen. There might be a little microphone button you can touch. Anyway, guys, thank you all for joining us. I will save this, and then I'll make this into a Instagram TV. I'll put it up on my account sometime in the next couple days, and then you'll be able to rewatch it. I can't hear you. I'm sorry. I think somehow it got muted. If he's willing, maybe we'll do this again at some point in the future, because even when he goes back to the Middle East, to the medical school that he teaches at, through the magic of the internet, we can always reunite. So, Rugged Mom, I love you very much. Thank you for joining us. You're a fantastic teacher, and we'll see you all a different day.